Good evening. Apologies, it seems like our stream got interrupted there for a minute, but we're going to start again. And I opened with thanking all of you for joining us. And this is a town hall of Senator Nancy Skinner, the senator for the East Bay. And I want to introduce my panelists again and let our Dr. Wachter, who was speaking when the streaming cut out. But anyway, so this town hall is about what do we do now? The COVID pandemic, we're at the end of the third year. COVID's not going away. So just how do we all, what's the best way to stay as healthy as we can, our families, our friends, and others? So I have these great panelists who some of you who have participated in our town halls before will have heard them because they've joined us both in the past. But I have Dr. Bob Wachter from UC San Francisco. He is the chair of the Department of Medicine there at UCSF. And I have Dr. Eric Kaplan, who is the state epidemiologist for the California Department of Public Health. And they are both wonderful to have agreed to participate with us. And I'm going to turn it over now to Dr. Wachter. Go ahead.
Thank you, Senator. Yeah, I'll give you a brief sort of update of the way I see the state of the pandemic. First of all, COVID will never go away. At least for the foreseeable future. So we're all going to have to navigate this sort of weird world where there is some risk, but the risk is nowhere near what it was 2 years ago. And I remember March 2020 when I was hiding under my kitchen table, fearing that I was going to die of this new disease. I don't think that way, and I think very few of us think that way anymore. And yet it's not right to say COVID is not an issue. It still is an issue. I think you still don't want to get it. I would say personally, having had 5 vaccine shots, including the new booster, the new bivalent booster few weeks ago, I no longer fear that I'm going to die of COVID or even to get super sick from it. But the prevalence of long COVID, of people having prolonged symptoms, is at least 5%, might be even a little bit higher. And so, and my wife, who is 6 or 7 months out from her case of COVID, still is fairly fatigued and has some brain fog. So I think it's still rational to try to be thoughtful and careful as you can be while getting on with life, because this is going to be a version of the life we live in forevermore. The case rate right now is quite low in the Bay Area, quite low in California, higher in certain other parts of the country. And striking to me today, I am comfortable eating indoors now in a way that I wouldn't have been a few months ago. Although I'm still careful, and I'm going out to dinner tonight with some colleagues from UCSF and choosing to go outdoors, even though it's pretty cold out. They have heaters. I think when I have a choice of indoors or outdoors, I'll choose outdoors. When I am indoors, particularly in a crowded space, I will wear a good mask, usually the better one behind Erica's head. I'm usually wearing a KN95, which is relatively comfortable and still offers very, very good protection. So on an airplane, in a taxi cab, in an Uber, on a bus, in a concert, in a movie, in the Safeway, I'm wearing that mask. It seems to me I don't really need to talk to anybody. Why take a risk of getting COVID in those circumstances? In a small meeting or a small get together with 3 or 4 people in my house or at work, I will be comfortable taking the mask off with the case rates this low. That said, I'm going to New York this weekend. New York, the case rates are about 4 times what they are in the Bay Area. And so I will not eat indoors in New York because the case rates are higher. My chances of getting it in exactly the same encounter are 4 times higher than they would be here. So that's kind of the way I see the current state of COVID. And I think Eric will get into where it's going, but I am of a mind that we're likely to be at probably the lowest point that we'll be now for a while, that it's probably going to be on the upswing, and we have to watch it carefully and see where things go. Final point I guess I'll make is, as a physician and a practicing physician, I spend my life thinking about the risks versus benefits of giving people antibiotics for their urinary tract infection or their bronchitis, or treating a blood clot, or giving them medicine to try to prevent a stroke. There's almost nothing that I do where the benefits so far exceed the risks as the booster. And whether that was the old booster or the new booster, it's sort of the same thing. There is absolutely no question that the benefits for pretty much everyone of getting the booster exceed the risks. Now, the booster's gotten a little bit of a bad name in part because of misinformation, and in part because it does not work as well as it once did in terms of preventing all cases of COVID. But it continues to work incredibly well in preventing severe cases of COVID, and that's the main reason to get it. Particularly if you're at someone at higher risk, over, let's say, 50, or have other medical illnesses, and you have only gotten 2 vaccine shots a year ago, you are markedly underprotected. And if you get COVID, you'll probably do okay, but there is a decent chance that you will get very sick and a small but real chance that you'll die of it. And you can make those chances go down tremendously by getting a shot that's completely safe. So if I were someone who had not gotten my new booster and I had not gotten either COVID in the last 3 months or had a booster in the last 3 months, that would be the first thing I would do tomorrow, is figure out a way of going out and getting this new shot.
Hmm. Well, thank you for that. And we will, of course, get back to you because we're going to go through a lot of our questions I have, and then our audience questions or our constituent questions in a little bit. But now I'd like to turn it over to Dr. Pon, our California State epidemiologist.
Great. Thank you so much, Senator Skinner. Pleasure to be with all of you this evening, and nice to be in my home jurisdiction, speaking to my fellow East Bay residents and Bay Area. I want to just echo and reiterate a lot of what Bob just said. And I think clearly COVID is here to stay. And to remind people, this is sort of similar to the virus that causes the common cold. And we have not yet figured out how to get rid of that either. And on that sort of spectrum, I would say, as we think about this and thinking about living with COVID, we should, think about, in some ways, what can we do better now for other respiratory viruses? So I think it's important to remember, flu is back, and it's about to start. I think we're going to see a pretty concerning season potentially, and we're seeing that in other parts of the country and the world. And there's a lot of things we've learned and we do better now with COVID that we didn't do in the past that we can do better with these other viruses. And we're seeing, you may start to hear more in the news too about a virus called RSV. Typically, it causes more problems in young infants, but also other people with immune system compromise or the elderly. So a lot of these same prevention things, being outdoors, wearing a well-fitted, well-filtered mask, which is why I'm advertising in my Zoom background, will really help us for a lot of these different viruses. And staying up to date on your vaccines. Get your flu vaccine, get your booster, as Dr. Wachter mentioned. Those are all really important things that'll help us protect us from, again, not only COVID, but other diseases as well. And but I think a key difference that was brought up that is really important to continue to reiterate is we're still learning about long COVID. And to me personally, even, and for my own family, that is still what concerns me the most. I do feel much better now that I have all these vaccines under my belt and that I've been boosted recently. That I will not get a serious infection and I won't be hospitalized. We were actually just remembering we got like an O2 sat monitor for home in 2020 because that was one thing you could look at, and people literally couldn't get enough oxygen when they were infected. But it's not. I mean, there's some predictors on who certainly is at higher risk for long-term impacts of COVID. But on the flip side of that, so many people who had mild illness who were previously healthy have had long COVID symptoms, including kids even. So I think it's really important to do what you can to prevent things, but also, yes, try to balance that with living the life you want to live, and certainly connecting with people is so important for people's mental health. We can all collectively acknowledge that and how important that is right now after the impact that we've all been through over the last 3 years.
And Senator, I'd add that as you think about why it's important to try to avoid COVID if you can, and I, by the way, I've not had COVID yet that I know of, 3 years into it, so, and that's probably partly luck and partly being careful. But people sometimes say, well, I had it already. At least I got, I was unhappy that I had it, but at least I got it over with. Now I don't have to worry about long COVID because I didn't get it. That's just not correct. So if you get it a second time, you're putting yourself at higher risk of getting long COVID, even if you didn't get it the first time. And if you did get it the first time, you're putting yourself at higher risk of having a worse case. So there's always a reason to try to avoid getting it, even if you've had it multiple times before.
Well, when we get to the constituent questions, a lot of them had things about long COVID, so we'll get into those in a minute. But, and I just want to say for those of you who jumped on recently, I'm State Senator Nancy Skinner. I'm the senator for the East Bay Senate District 9, and we are doing our COVID What Now town hall. And I've got two great panelists, Dr. Erica Pon, who is our California State epidemiologist, and Dr. Bob Wachter, who is chair of medicine at UC San Francisco. So now we'll continue, and I have a question. Dr. Wachter, you mentioned that infection rates are low right now in California, in the Bay Area particularly, and you compared to New York. So for those of you who may be traveling to New York, they're about 4 times higher. Now, free testing from the feds is no longer available. A lot of testing sites have closed. How do we know that the infection rates are down? What's our approach now in testing? So let's just start with what's our
Yeah.
approach now in testing, and how do we?
Well, first of all, the
where we
tests are
track
not,
the rates?
yeah, the tests are not free, but I actually just went to Walgreens the other day to pick up some tests, and they say, oh, your insurance will cover this.
Uh-huh.
So the insurance is covered 4 test kits which is 8 tests to have around the house. So it's worth checking. Um, but you're absolutely right. So most of the testing that's going on now is people testing themselves at home. And those don't get reported to Erica, so she has no idea when she's doing her numbers. And so when I look at the cases, for example, reported in San Francisco, or the cases per 100,000 per day, which are metrics I look at, mostly looking at the trend, because the raw number is a substantial underestimate of the number of cases. But there are other reasons why looking at that trend we know is helpful, because I've been following this very carefully for 2.5 years. Those trends in the numbers of reported cases, even though they're underestimates, correlate quite well with other things that don't have this problem of underreporting. Wastewater, you've probably all heard about that. We can test sewage to see how much virus there is in it, and so those numbers, if the wastewater is going up, the test positivity numbers will go up. At UCSF, we have a number that's not publicly reported, but it's basically the percentage of people who have no symptoms of COVID whatsoever who are testing positive. You come in to get open heart surgery at UCSF or to have your hernia fixed, we're going to test you for COVID. And so that number is a very reliable number, and that number correlates quite well with the publicly reported test numbers. And so when you look at publicly reported test numbers, you're really looking for the trend. And I'd say right now, the numbers are low, and if they start going up, chances are the wastewater will go up, the asymptomatic test positivity rate will go up. And what that simply means is if you have a given encounter, you're going into a restaurant or a bar, the same encounter can be very differently safe based on basically the number I care about is what is the probability that my waiter has COVID, or the person sitting at the table with me or the next table has COVID. And when I'm following numbers and making decisions about masking or whether I'm going to eat indoors, it really is based on, do I think the case rates are low? Have they gone up? And I think looking at the publicly reported numbers, yes, they're underestimates, but the trend is still useful.
Great. Dr. Pond, so given that you're the state epidemiologist, we just heard from Dr. Wachtberg how, he's looking at the publicly reported numbers. I suppose you're one of the people who is giving those publicly reported numbers. So what would you add to what he described? How is California? What are you basing this information on that tells us what the positivity rate is?
Yeah, I mean, just to really echo a lot of what was just said, it's really at this point the trends that are really helpful, right? So there is publicly reported test positivity as well. And yes, that is only the ones that are reported to us, but those trends are really helpful. And so, for example, statewide, it's down to about 4% now. And that is definitely, lowest than it's been in a long time. And then we kind of look at that as well, at sort of different age groups, et cetera. And then we are very closely monitoring the wastewater. We do have a dashboard, happy to send the link later, that, people can look in their area, and we watch those patterns very closely. With those trends, the other, of course, important thing is hospitalizations, and those are important. They are what we would call a lagging indicator in many ways. So usually we see the other things go up first and then hospitalizations go up later. But it is very reassuring, I think, that we are thankfully at a lower number now. Like we were looking at this compared to, the last two kind of October, November-ish times. And we're definitely thankfully starting at a lower number as well before we're kind of heading into the winter season. So all of those things are absolutely reassuring. We're working on more and more sort of ways to have what we call sentinel surveillance that is very intentional with various healthcare systems or other things as well. But those are all the indicators we're looking at. And I just wanted to put a plug into that health insurance, again, does pay, they must pay or reimburse you for, as mentioned, 8 tests per month. So I put a link that we can send later.
8 tests. So I want to reiterate that. So your insurance, and of course, California regulates through the Covered California and through your employer, that, and the federal government also put that into place, that all of us with health insurance, you will have your insurance will cover 8 tests per month. So that's a good thing to know. I didn't know that.
Yeah, so we'll make sure you get some links that you can send out to for how like instructions and guidance for people to get those. And the other quick thing about testing, just you know, the other, I think I love how Bob always talks about, you know, how he's thinking about it personally. And for example, when we're going to go have a meal with my elderly parents, I make sure our family tests before, because I don't want to be the one who's bringing it to them, because I'm still worried about their risk for serious illness, even though they've been vaccinated and boosted. So
Now
that's
that
the
you
other way
said
you
that,
can use them.
now that you said that though, you know, some of us wonder about the effectiveness of the rapid test. So could we, so, you know, I'm going to say I'm in the same situation as you. I'm going to go see my elderly relatives or a immunocompromised relative. If I take that test, you know, the day of or a couple hours before, how rapid, how much does that assure that I am not transmitting the virus, that I wouldn't infect somebody else?
Yeah, from my perspective, it is a very decent proxy for your infectiousness, right? So yes, we know, especially with more recently, we're hearing more and more that people might take a few days to test positive, even after they've had symptoms or anything. Certainly, if you have symptoms of anything, you shouldn't be visiting anyone who might be, because again, other viruses as well, flu and RSV are also things that can cause really serious illness in someone who's elderly. So any symptoms, even if you're testing negative, I would still avoid exposing your loved ones or others who are compromised. But I think the test, you know, even if a couple days later you test positive, if you were test negative that day, it's a decent proxy. It's not perfect, and certainly the, you know, the traditional laboratory PCR tests are more sensitive, but I think it is a reasonable proxy for how infectious you are, how much virus is in your nose that you could be, you know, transmitting to other people.
Right. That's good to know. I know that's something a lot of us wonder about because, um, you know, now that we are going to be going and invited anyway to more events, whether we should be using those tests before we go. Um, which my next question was going to be: are we expecting a surge, even though our numbers are low right now? Are we expecting a surge, or can we make such a prediction, or not? And maybe,
I'll start. I think it would be surprising if we didn't see something of a surge. The case rates are so low right now. I mean, Eric mentioned the hospitalization rates at UCSF today. There are 7 COVID positive patients in a 600-bed hospital. In January, there were close to 200.
wow.
So it's remarkable how low they are. So it's just, it can't get much lower. And then you think about the forces that may push it to go up. Winter will drive people inside. There are these new variants that are coming out that are at least somewhat immune evasive. They're not massively scary, but they seem to be taking over from the BA5 variant, which means they're a little better at infecting people than BA5. Unfortunately, in the old days, there was something, if you started to see a surge, people immediately started being more careful and putting masks on. I'm not confident that will happen, at least to the same degree that it used to happen. So that used to be some back pressure against a surge that probably is mostly gone. And unfortunately, a lot of people are not getting the new vaccine. So their immunity is getting a little bit worse every single day. If your immunity came from a booster or vaccines you got a year ago, or an infection you had a year ago or 8 months ago, your immunity is worsening. So in the constant battle between who wins, the virus or your immunity, I think I would unfortunately bet on the virus now. And I think we're likely to see a surge. Will it be a massive surge the way we have seen previously? I'm guessing no, but I think we've got to all be humble. If you go on the CDC website and you look on the website that they have that used to have all these projections and predictions, they now have a line that says we no longer put these up here because we're not confident in them anymore because we've all been burned so much. So if I was a betting person, I would bet there will be an uptick in cases. I would bet enough so that people like me who are reasonably comfortable eating indoors now will stop doing that during the surge, and I would bet that it's not going to be a massive surge with a lot of deaths and a lot of hospitalizations, but certainly more than we are now. That's all a guess, though.
Okay. So I'm going to jump right into masks since you mentioned, and I'm going to ask Dr. Pond, since you have the masks images behind you. Um, you know, there are some of us who are still using masks in the crowded spaces, and Dr. Wachterd, you just mentioned that, you know, if cases go up, you would hope that people started to be more cautious or more protective. And so you mentioned masks. So here's the big question. How effective are they? If I'm the only one in the room with the mask on, am I protected, or am I protecting others if I have, and what mask should be used? Some of my constituents wrote in and said, even N95s are not effective. So Dr. Pond, how do you want to add to that or answer that?
Yeah, I'm happy to. So again, yeah, I think it's like everything else, there's like a spectrum, right? So the best mask and it is well fitted and well filtered, right? So it's all about fit too. So I have my KN95 here, but what you really want to do is make sure there's no gaps around there. And then the filtration is what is really great about the N95. And, in a lot of these tests, actually the KN95 is basically equivalent, but the fit sometimes, or the fit testing that you hear about, like that, healthcare workers get, is not necessarily the best seal. But if you can have a good seal and a well-filtered mask, you are very well protected, which is why we really are trying to emphasize the importance of wearing a well-fitted, well-filtered mask. And even if you're the only one in a room, if you have a well-fitted, well-filtered mask, they work really well. So I think that's sort of my bottom line on that. I think I would agree. I want to mention that I agree that I'm, someone who's been super cautious as well, being in the field I'm in, and I have been feeling more comfortable, just in the very recent sort of weeks with not necessarily wearing them everywhere. But I am definitely, just to kind of touch on your other question, I think as winter comes and we start seeing again increases in not only COVID but other things, I'm probably going to start wearing it again, especially in more crowded indoor settings and places like that. So I think it's a good tool that we have.
And it's very hard. I have to say, I was at a medical meeting last week. There were 80 people there. No one was wearing a mask. I wore mine.
Wow.
And I felt like, they can do what they want, but there's no question in my mind that me wearing the mask is significantly protective for me. If I happen to have COVID, it would protect them as well, but it protects me not perfectly, but very, very, very well. And even with the case rates as low as they are now, in a group of 80 to 100 people, there is about a 50-50 chance that there is someone there who has COVID and is infectious, even if
Wow.
they all feel fine. That's
Okay.
with very, very low case rates. If the case rates go up, that number will be 100%. And
Right.
so I've always mused that when I walk on an airplane, if the flight attendant held up a sign and said, I can guarantee that there is someone on this plane who has COVID and is infectious, I think a lot more people were in masks. And that turns out to be true. In a group of 150 people, you can almost be certain. And that's why I wear a mask on the airplane.
Uh-huh. Good to know. All right. So now I'm going to jump into, so COVID's here and we'll get some uptick. How are immunocompromised people, whether they're elderly or just have other circumstances that make them at higher risk for the severe consequences of COVID, how should they navigate now that these mitigations are being lifted? We're pretty much seeing most everywhere you go. I mean, you just described being at a medical meeting where you were the only one at the mask. So how should immunocompromised people navigate this? Any recommendations?
Well, I guess I'll start. I would parse your question, Senator, in two different buckets. I do not consider an 80-year-old who is who inevitably probably has some medical illnesses, has high blood pressure, or high lipids, or even diabetes, as being the same as someone who's immunocompromised.
Okay.
For the person who is just elderly, their immune system does not work as well as it used to. And that is why they need to be up to date with their vaccines. And when I say up to date with their vaccines, I mean that they have gotten the new booster, unless they have had a booster within the last 3 months or an infection in the last 3 months. There's no question their risk of a bad outcome with COVID is much higher, and they need to stay up to date with their vaccines. And it really is sad and shocking, and there will be thousands of deaths because elderly people have, for whatever reason, chosen not to stay up to date on their boosters, in part because of misinformation. So that part's easy. I think for people that are truly immunocompromised, and by that I mean people who are on active therapies by and large, that harm their immune system on purpose. Those are they're on chemotherapy for cancer. They have a cancer that affects their immune system, like leukemia or lymphoma. They have rheumatoid arthritis or lupus or inflammatory bowel disease, for which they're on very powerful immunosuppressive, because that's what they need to thwart their illness. For those people, they're in a harder situation because they should get all of the recommended boosters, but there is a chance that they will not work in the same way.
Mhm.
There's a monoclonal antibody cocktail called Evusheld that has been recommended for the last couple of years. And at least for now, we think it still works. The question will be whether it continues to work as the new variants come out, and there's some possibility it will work less well. And so for an immunocompromised person, that is, you need to talk to your doctor, sort of get a sense of how vulnerable you are. And it may be that, with case rates as low as they are now, you are more comfortable going indoors and eating with family or friends, but you want to do everything you can to stay safe. I would do testing of the people around you before they come in close contact with you. I would keep the windows open at Thanksgiving or in other indoor gatherings. I think, to say you can't have any human contact because of, nobody can live like that and nobody wants to live like that. So I think it's not the way it was 2 years ago. Immunocompromised people should get all of their shots, should take Evusheld if their physician recommends it, and also act as carefully as they can with things like masks, with things like ventilation, and with liberal use of testing.
Great. So, Dr. Pond, we've got now into, obviously, both of you have highly recommended that everyone get fully up to date on the vaccinations. And as you can imagine, with the different questions that came in from the constituents, there's a lot of feelings around the vaccinations, some pro, some con, and there's worry or questions. I don't want to say worry, but let's go into this long COVID issue. So we know that long COVID, there's a significant incidence of it. It's not the majority of people who get COVID will get long COVID, but it's a high enough percent that it's a bit scary. So what is is there any evidence that being fully vaccinated, I mean, with the even latest booster, that you are less likely to get long COVID? Is there any evidence yet about that?
So I'll start and just say a few things. So first of all, you are still less likely to become infected, right? So again, if you're avoiding COVID to begin with, you're less likely to become infected. Again, it's not as effective as it was, but it's still, you are still much more likely if you're unvaccinated versus vaccinated to become infected. So
the transmission, again, other than your clear communication that it protects the individual from the severe illness or even potentially getting it, you make the case for the vaccine in terms of other people.
You want to start with that, Erica?
Sure. And to make sure I'm not 100% sure I know
I think it's one of those classic where, there are constituents who we know, and not just people, are in our population that feel that they've decided that the risk is worth it to them to get COVID. So what is the argument? And if they don't think it's going to minimize the transmission to somebody else, what is the benefit of getting the vaccine?
Yeah, I mean, I think, again, I would start with, first of all, there is still, and, admittedly, the gap is shrinking because so many people have been infected with COVID as well, and that provides some immunity. But our data for California still shows that you're more likely if you're unvaccinated to be infected than if you're vaccinated. So that's one thing. And I also think it's pretty interesting. There's other survey data just talking about people's behaviors in general as well. And I think people, there are correlations between people who are vaccinated and there are other kind of precaution measures. So again, I think as far as benefits because I did see a pre-question about like, if you're asking people they're vaccinated or if you're trying to verify that, I think there's both less risk that they could be infected. They're also probably less risk of being infected. I mean, and these are the difficult things, again, to study as far as confounders, but a lot of their behaviors are different too and less likely. So it's still just, again, I mean, if we think about all vaccines too, right, there's really this important kind of community immunity we're all trying to strive for to help get us, to the next sort of phases and get to really protect our community from infection.
Yeah, I guess I mean, the question is demonstrates how complex this is. It's sort of, you get into a pretzel very easily here. There's just no question. The data are completely clear. People can dispute it all they want, but the research is just crystal clear. If you're vaccinated, you're less likely to get COVID. You're less likely to die of COVID. You're less likely to be hospitalized. There's just no there's no scientific controversy about those issues. I don't know of any research that says that you're less likely to transmit a case of COVID if you happen to get it. So if you take two people, one vaccinated and one unvaccinated, they both got COVID, are they differentially likely to transmit it? And I think the premise of the question was maybe they are because they have a milder case, but they don't know it, so they're more likely to hug somebody. That's a lot of hand waving. I don't think there's any evidence. I think the main benefit of the vaccination is you're less likely to get COVID, and therefore you're less likely to spread it if you don't have it. And you personally are less likely to die of it. It seems to me enough, that's good enough reason for me to get it. In terms of if you then get COVID, is it any differently likely that and you're less likely to get long COVID, as we discussed. Are you any differently likely to spread it? I don't know any evidence that says that you are, either more or less. I think if you've gotten a breakthrough infection, you got COVID and you're vaccinated, I would assume that your chance of giving it to your spouse, let's say, is about the same as if an unvaccinated person gets COVID. Maybe at the margin, there's some difference there. The unvaccinated person maybe on average has a slightly higher viral load and maybe is a little more likely to transmit it. But I would treat those two as sort of as a difference that's not particularly important. The main differences are the things we know the vaccine does, and those are really so unquestionably the benefits outweigh the downsides that to me this is not a hard call, at least scientifically.
Okay. Now, status of vaccinations for 6-month-old. So 6 months old, are they still in the situation that only the original, the first shots are tested and safe for them, or at least available to them?
Yes, that's right. So the new booster or the bivalent booster is only available for 5 years old and up. So that 6 months to 5-year-old range can still get the original booster. And I think that's where actually
shot in the original booster. So
that's right. That's right.
Okay.
So again, the vaccine again is holding up on, that booster is still an important booster to help with immunity and preventing against any serious illness. And that's an important age, actually, just to mention. I think, often with infections, it's these sort of extremes of age that are at risk for more serious illness. And so it is really important to get those boosters. And we're seeing really low uptake, unfortunately, with kids under 5. So definitely want to emphasize to all the parents out there or grandparents to encourage your families to get your kids vaccinated. I'm speaking as a mom, as a pediatric infectious disease doctor, and a public health official. Get your kids up to date on vaccines, get them flu vaccine as well. Again, we're seeing a lot more kind of in with all these respiratory viruses circulating right now. So it's really important to get to use the tools we have to protect ourselves and our loved ones.
Great. Now, what in terms of timing, if somebody hasn't gotten the new bivalent booster yet, and they're expecting to travel sometime between now and, I don't know, January, February, let's say, anytime, December, January, February, to a country or a place with high incident of COVID, what's the best timing? When should they get it, like 3 weeks before, 2 months before? What's best timing?
I'd say tomorrow. This is like amateurs trying to time the stock market. It never works. You have no idea what's going to be a high incidence place. If it is now, it's probably not going to be in February. Maybe now in the Bay Area is not bad, and in next month it's higher. So it just doesn't work very well to try to time this out this elegantly. You try to do it and you're waiting, and then you get exposed to COVID, at home or in a restaurant, and you wish you'd gotten your booster now. So to me, the timing is if you have not gotten a push on your immunity from either infection or a shot in the last 3 months, it's time to get it. And at the same time or nearby, getting the flu shot as well is the right time. How long does it take the vaccine or the booster to work? It takes a couple of weeks for it to reach maximal effect. So you certainly want to do it at least a couple of weeks before a high risk activity. There is some, as people are trying to game this out, yes, at least with the old booster, the effect in terms of lowering the probability of infection lasted for about 2 months and then did wane. So if you knew for sure that you were going to stick your head in a massively COVID-laden, body of air 3 months from now, you could say, all right, maybe I'm going to wait a month or 2 months to be sure. But it's just life. This whole thing is just, there's so many uncertainties that I think you're more likely to get yourself in trouble, and you're better off just getting yourself boosted if it's time.
All right, Dr. Pond, I don't know if you want to add anything to that or not.
I would agree with all that. I think, there was some with prior boosters, it looked like maybe they rev up your system a little faster than like other traditional vaccines that typically take a couple weeks. And I think the jury's more out on the most recent ones, but I absolutely agree. I think, especially if you're going to be doing high risk activities, I would do it at least 2 or 3 weeks prior. And if you're, trying to game it out, I agree with what Bob said about the peak activity. And yeah, no, I don't have anything else to add.
Okay. Now, Dr. Pond, this question's for you. Some of our constituents are wondering, is there a plan for getting California nursing home staff and residents vaccinated with the new subvariant booster? And what are the testing requirements for nursing home staff and residents?
Sure. So we have a whole kind of long-term care facility toolkit to help sort of different health providers and long-term care facilities to get their residents vaccinated. And there's a lot of efforts happening with the various sort of associations. And I know a lot of local health departments also are prioritizing that. And a lot of pharmacies are still assisting with those efforts for long-term care facilities. There are no longer any testing requirements for residents. There were, and that was, one thing that we at the state level sort of, and actually CMS around the same time, I think, had reduced some of those testing requirements. So they're not required. I think, again, if we think about all of our tools, testing is one of them. And so if you are visiting someone that you want to go see in a long-term care facility, I absolutely would encourage you to test right before. And I think, again, when you've been exposed, when you have symptoms, before you're going to visit or spend time with someone, or you could, if you're the person, just to the other question about if you're the person who's immunocompromised, ask other people to test before they're going to spend time with you, especially if it's indoors or. So those are other just tips to share.
So back, continuing on to state of California specific things. California has the COVID paid sick leave. It's available to most people who are employed. It's but certain size of companies. So if you work at a very small business, it's not necessarily eligible to you, but it's a benefit that the governor asked for, the legislature passed, that assures people get additional sick leave for COVID. Now that's expiring in the end of December, even though we know that COVID's not going away. So any thoughts on that or advice to folks around that expiration of the COVID sick leave?
I don't have other information on that right now. I think we have mentioned that the state of emergency will not end till the end of February. So there may or may not be, other kind of things that we'll be looking at that. But I encourage all employers certainly to give sick leave in general. Again, and as we normalize COVID, there are other reasons too. You want your employees to stay home and to pay them to do that so that they can, avoid infecting others.
Yes, yes. So for those of you listening, if you think that you are employed by a company that should be providing the paid sick leave and perhaps the COVID sick leave, and you perhaps haven't utilized it and you get COVID between now and December 31st, you can go to the website of the California Department of Industrial Relations. They have a section on their website called COVID-19 resources, and it describes that sick leave and who can access it and how you access it. So I encourage those of you to check that out. But it does expire at the moment, expires on December 31st, 2022. The COVID state of emergency, Dr. Pond, you referenced that the governor will be lifting it in February. What's practically does that mean?
We've already kind of gradually over the last calendar year, I think, kind of scaled back. So when we have these states of emergencies, there are a lot of sub provisions on each of that. And so gradually those things have been winding down. I think the things that will end after the end of February, some of them have to do with who can give treatments at some of our treatment sites, whether nurses or certain scopes of practices around who can vaccinate or provide treatments, who can do the lab testing. So there are things like that. But I think, the important thing we want to emphasize again is that we need to learn to live with COVID in the long term, as we've been talking about this whole evening, and really utilizing all of these tools that we're talking about, whether it's masks, good ventilation, doing things when you can outdoors, testing before you're going to spend time with a high-risk individual. And the other really important message, actually, we haven't talked about is treatment early. So, we have an oral treatment now. It's easily available. We have enough supply, and there's
And
not enough.
that oral treatment.
Paxlovid
Okay.
is one of them. There's another one called molnupiravir, but really the main one that is sort of the drug of choice, unless there's any other contraindications, that is outpatient and oral. And we have a lot of it, and it's being underutilized. And people, again, who are at higher risk of being hospitalized should really reach out and seek treatment early. It's, just like actually treatment for flu, you want to get treated early. We do have some what we call test to treat sites across the state, but really check with your healthcare provider first. But that is another tool that we have now that we didn't have in prior years. And, certainly prior to the last winter surge, we didn't have it so easily available. And that's another way we can really reduce the seriousness of this illness.
Great. Thank you for bringing that up. Now, as we start to wrap up, I'm going to give you each a quick ability to close, but I want to indicate to listeners, if you had submitted a question that we didn't get to, my staff will be responding. We have folks' emails, so we will do our best to respond. And if we need to turn to Dr. Vaughn or Dr. Wachtberg to help us, we will. But people will get their questions answered. And as you both have mentioned, the vaccines, the booster vaccines of all sorts, if you've never been vaccinated, are still available, but the boosters are available. And perhaps in each of your close. And right before I give you that close, I want to also just reference to folks that everyone who's registered to vote would have gotten their ballots. So please submit those. You can submit your ballot without putting postage on it, or drop it off at a voting drop-off box. And if you have never registered and you still want to vote in this election, California has a great voter choice law, which allows you to register even the day of. So Election day is Tuesday, November 8th. You can wait as long as that even and go to a polling place or to a registrar of voters in case you want to do that. But California's made it as easy as possible to vote. So I encourage all of you to vote. And now I will turn it to each of you if you want to mention just the availability, where people can get those vaccines, and anything else you want to do as we close. Dr. Wachtberg.
Thank you for the opportunity. And I in some ways, coming out of this, and we'll never be out of it fully, but it's certainly a different world, is almost as hard as going into it. Going into it, we had to learn all sorts of new ways of doing things and measuring risk and understanding the science and where do you get reliable information. And I think a lot of people are struggling with how do we rethink our life now in this new stage. And just to know we're all going through that. It's really a hard thing to do. We've learned a lot of lessons. There have been a lot of tragedies over the last couple of years. But it is, I think, a good time to kind of take a step back and say, if this may be a version, and maybe a decent version of what our future looks like COVID-wise. What have we learned? What have we learned about the science? How do I live my life so that I get maximum joy, and that involves seeing people and friends and family, while also not taking unnecessary risks? And the level of risk is going to be partly, up to you and up to what your risk is. So, how an 80-year-old acts, it might be different than how a 30-year-old acts. But I think it's important for everybody to recognize that COVID is here, and it's now a good time for us to really think carefully about, how do I want to live my life and make sure that I'm not taking undue risks, but also get back to a version of life that feels like it's worth living.
Great. Those are great. That was a good way to end, because I think really the point of this was just how do we navigate the risks now? Dr. Pond.
Yeah, I think just to add to that, I think the other way, sometimes we've talked in public health about harm reduction, right? Like you're really just trying to, we used to talk even at the height of things, where these Swiss cheese layers, right? No layer is perfect as far as our protection or tools, but the more layers you use, the more protected you can be. And you do have to make those choices. And absolutely, personal and social connection is such an important part of our wellness and social well-being. But you can, again, and as mentioned, depending on kind of what your underlying risk is of serious illness or other things, you can navigate, what is more important to you. And then what can you do for that event that is important to you to reduce your risk, but still be able to partake in it. So I think that's really important. And, just to reemphasize, I think there are so many lessons learned. And can we do some things better? Can we get through our winters better and have, if we actually all wore masks and a lot of cut indoor settings, maybe we could actually, it was interesting to see when flu sort of disappeared. But, now that a lot of those other kind of measures we used for COVID that helped prevent circulation of other SARS, they are back. And so can we use these, empower ourselves and our communities to use some of these tools every winter to help reduce kind of your own illness and your community? And so I think that'll be something we should all look forward to and think about. And just again, and vaccines are really the longest lasting thing, right? That really can help protect you and your loved ones.
Well, thank you both very much for sharing your expertise, sharing your thoughts. I really appreciate it. And I also want to thank my staff for doing the good work of organizing this and collecting our constituent questions. And I want to thank the Senate Democratic Caucus staff who put together the Zoom and the streaming for us. So this is a wrap. This is our COVID What Now Town Hall, Senator Nancy Skinner, and I'm thanking Dr. Bob Wachter and Dr. Erica Pan, and we will see you again at sometime soon. Thanks so much.
Good evening. Thanks.